Okay, thank you. So welcome everyone this afternoon. It's my pleasure to introduce this session this afternoon about combined physical and psychological programmes. My name's Louise White and Dr. Jim Greenwood and I are moderating this session this afternoon. We're both physiotherapists. I work in Birmingham and Jim is based in London, and we're also both representatives on the National Back Pain Clinical Network. So the format of this session this afternoon is that I've recorded an introduction to the topic first of all, really just to give a bit of background to the session. And then after that, we've got 5 different presentations sharing experiences and outlining a range of different examples of CPP programmes currently in operation within the UK. Now, we'll have time at the end of the session for some questions, so please do post your questions or comments. We'll try and get through as many of these questions as we can. And if you've got a question specific to one of the presentations or presenters, then please, if you could specify that, it just makes the moderation process a little bit easier. So I think we'll play the first video, the introduction, and then take it from there. Thank you.
Delivery of combined physical and psychological programmes was highlighted in 2013 by the Spinal Task Force as the most serious gap in UK spinal services. Since then, service delivery has progressed and there's been a lot of work and drive to implement the National Back and Radicular Pain Pathway. And within this work, our group, the National Back Pain Clinical Network, was formed. It's difficult to get an accurate view of current CPPP services across the country, but we believe that further work is needed to improve delivery of CPPP services. So today's session provides an opportunity to begin to explore this further, looking at various existing programmes and also potential support for improving delivery. To start with, it's worth briefly reminding ourselves of the magnitude of the back pain problem. Back pain has been identified as the #1 cause of disability globally and estimated at 60.1 million years lived with disability in 2015, with numbers continuing to rise. And bearing these quite shocking statistics in mind, it's important that we continue to develop evidence-based services to reduce this problem. The complexities of back pain are well recognised and not everyone requires the same level of intervention. We are fortunate within the UK that the National Back and Radicular Pain Pathway provides us with a framework for delivering a stepped care approach based on biopsychosocial principles. So just as a reminder, the first tier intervention is including provision of advice and guidance with the Start Back screening tool guiding identification of low-risk patients. The next tier of intervention is core therapies, and for those requiring a bit more intensive or long duration input, comprehensive, combined physical and psychological programmes are recommended. So looking at this another way, CPPP could be considered as a spectrum with core therapies and more intensive CPPP programmes our main area of consideration today. Now, as you're aware, the National Back and Radicular Pain Pathway was compiled to support implementation of the NICE guidelines, and so it's helpful that their recommendations are aligned to this stepped care approach. So, looking more specifically at the guideline, there's recommendation for psychological therapies, but only in combination with exercise and/or manual therapy, and this is often referred to as low-intensity CPPP. And then for those requiring more intensive input, the recommendation is to consider combined physical and psychological programmes. So this is for patients with significant psychosocial obstacles to recovery, or when previous treatments have not been as effective. The guidance here also fits with the inclusion criteria laid out in the National Back Pain Pathway. And helpfully, there are clear exclusion criteria also, which are aligned with the inclusion criteria for patients more suitable for pain management services. The back pain guidelines, the back pain pathway also provides us guidance with the content of these programmes as listed here, which I won't go into in more detail today. So far, this seems quite straightforward, and the evidence is helpful that we should be providing CPPPs. However, there are some further points that I'd like to highlight for consideration and perhaps for further discussion later on in the session. Firstly, the terminology used to describe services is somewhat confusing at times. Cochrane used the term multidisciplinary biopsychosocial rehabilitation, or MBR, and they concluded that such programmes were effective for chronic back pain. Within the National Back and Radicular Pain Pathway, multidisciplinary programmes are also recommended, and they use the term comprehensive, or MCPPP, requiring multidisciplinary input, with both the Cochrane and the back pain pathway recommending multidisciplinary involvement. However, bearing in mind that the back pain pathway is the implementation of the NICE back pain guidelines, it's important to consider the relevant evidence-based sections within the NG59 guidelines. And in fact, this is entitled MBR, or they use the same term as Cochrane, Multidisciplinary Biopsychosocial Rehab. And it was concluded that after further discussion with the guideline development group, it was agreed that these programmes may in fact include various components delivered by one individual, and that multidisciplinary aspect can apply to interventions included in the pathway across disciplines and not to the number of people or disciplines delivering this. Therefore, it was concluded that CPPP programmes could be uniprofessional, but with a multidimensional content. Sometimes this is referred to as psychologically informed rehab. So if we are accepting the MCPPPs are having multidisciplinary components, then that can be delivered by single professionals with appropriate training, then perhaps this makes such programmes more within our reach, and this is a further point for discussion perhaps later. There are other questions also for us to consider. Firstly, we don't really understand yet the optimal dosage for CPPP. For example, in previous NICE guidelines, there was recommendation for a 100-hour programme, although the more recent guidance takes a much more relaxed stance, with no specific duration or intensity recommendations. And we don't have evidence to guide the optimal number of participants per group, the duration of the programmes, or the best locations, or maybe it's better to increase intensity or interventions earlier in the pathway. Also, the benefits of individual versus group programmes remain unclear. For example, cognitive functional therapy concepts tend to favour individual programmes. More recently, another question is around virtual versus face-to-face. Another point is for us to explore and consider is understanding current delivery and the associated difficulties. More work's needed to explore what the current national picture is with CPPP provision, and also what's needed to be developed for such services further. And this is certainly an area of further interest. For example, are barriers due to cost, commissioning, skill, confidence, fatalities, etc.? So in summary, there is consensus for a biopsychosocial approach and for provision of combined physical and psychological programmes. However, the evidence doesn't yet seem strong enough to direct precise delivery. Now, we could look at this as a problem or as an opportunity to develop services that we think best meet our patients' needs. Within this session today, we've got 7 presenters offering insight into 5 different programmes that they're involved in. We hope this offers ideas for development of services in other areas of the country, and we're keen to gain better understanding of current services and barriers to implementation. So please post your questions and let's start discussion on this topic. Thank you for your interest, and I do hope that you find this session useful today.
Good afternoon. Today I'm going to talk about the Back Skills Training Programme. Professor Sally Lamb is the Chief Investigator for this work, and it's been a massive team effort over the last 15 years with substantial investment from the National Institute of Health Research. The Back Skills Training Programme applies a cognitive behavioural approach to managing back pain. It's based on the understanding that there's a relationship between how we think, how we feel, and how we act. Back pain can lead to unhelpful thinking, such as hurt equaling tissue harm. These thoughts then influence how a person acts and feels. The aims of the BEST program are to undo these unhelpful beliefs that people can have about back pain, and to provide skills and motivation to become more active despite having back pain. It focuses on helping patients reevaluate their thinking, reduce the use of passive coping strategies, and to promote helpful behavioural responses. The BEST program consists of an initial one-to-one session where a clinical assessment is conducted and the patient sets goals for the program, as well as selecting their home exercises. There are 6 group sessions of 90 minutes each, and each week a different topic is covered. All the group sessions cover the same format, including homework, which is part of the CB approach. Exercises are also an important element of the program, and the patient selects these during the one-to-one session, and you can see some examples of the exercises that they choose from. The exercises are then reviewed each week during the group session as required. The other focus of the program is on increasing physical activity. The BEST program was developed and then tested in a large clinical trial at the University of Warwick, including 701 participants. And we found that participants randomized to the BEST program had greater improvements in disability scores and pain scores over the course of the 12 months. We also found that when we followed people up at nearly 3 years after randomization, that these improvements had persisted, and this is quite unusual for a rehabilitation intervention. It is also found to be cost effective. On completion of the trial, we needed to find a way that we could facilitate the implementation of the program into routine clinical care. During the trial, the physios attended a 2-day training course, but it wasn't going to be possible for us to provide this training ongoing. So we needed to find another solution. And the solution was to develop an online training course. The initial version was developed by Dr. Helen Richmond at the University of Warwick as part of her PhD. And following this, an enhanced version was then launched in March 2016 from the University of Oxford. We carried out an implementation study which was funded by the Oxford Clerk. We evaluated training outcomes in the 586 course completers from 101 NHS trusts. We also measured clinical outcomes in a service evaluation. This was conducted in 34 physio departments across 21 NHS trusts. 160 groups were delivered as part of this study, involving 923 patients. On training completion, the majority of learners were confident about their ability to implement the program. However, we found that confidence in capability to implement the program was significantly lower. So the difference between ability and capability was that ability is more their personal confidence in their own ability to run the group, whereas capability was about implementing within their department, and this was more challenging. At 6 months, we followed up participants, and we had a reasonably low response rate, which is quite common in these sorts of studies. We had 148 respondents, and around a third of these had run at least one group from 27 trusts. At different points in the study, we asked about potential and actual barriers. We found that there was perceptions around lack of suitable patients, patient dropout, or reluctance to attend the groups. And this perhaps was related to a paradigm shift that was needed to move from a biomedical approach to a biopsychosocial approach, as is done in a CB approach. Sometimes it was more practical things like space to run the groups or staff capacity and time to introduce change. This was often accompanied by lack of managerial organizational support, and sometimes there were funding issues. When we look at clinical outcomes, we were interested to see whether the clinical outcomes achieved in routine care were the same as we found in the trial. We found that there were significant improvements in pain, although they were somewhat smaller than we measured in the main trial. However, the changes in function were very similar. Patients were also highly satisfied with the service being delivered. And all in all, we felt that this was a successful translation of an intervention from a clinical trial into clinical practice. The online training now sits on the FutureLearn platform, and you're able to access that there. There is courses running at the moment, and you can sign up. What is needed to run the best program? Well, my first suggestion would be to complete the FutureLearn training, because it not only gives you the skills to deliver the course, it also provides you with all the materials which you can download during the training course, both the therapist manual and prompt sheets to help you run the training, but also the patient materials. We found from our research that support from senior staff and management is vital. The other thing that's needed is some equipment and space. Generally, you need a flip chart or a whiteboard. You need some space where you can sit up to 10 patients, and also some space where you can check the exercises at break time. I'm just going to go through some frequently asked questions now. The first one is, how do you select patients to take part in the BEST program? We found generally that the program is suitable for all different types of people with back pain. We have done some data analysis trying to identify subgroups that respond best to the program, but actually we haven't identified any, and we would say that it is recommended for anybody with persistent back pain. In terms of numbers in the groups, we recommend about 6 participants. Sites tend to book between 8 and 10 patients into the group to make sure that you've always got good numbers so that you can have a good discussion with patients. And we also know that sometimes people will be sick or on holiday, or the groups may not be for them. We get asked if the one-to-one session is necessary, and I would say yes, it is. It's really important to build rapport, but it also helps you to identify unhelpful beliefs that need to be addressed during the group. And it's also the time where we set the individual home exercises and set goals. Sometimes we get asked if you can adapt the program. We have only tested its effectiveness in the current format, but we know that some sites have successfully made adaptations. This can include just changing the number of sessions and having slightly longer sessions, for example, three-hour sessions. Other sites have added a more structured exercise session to the end of the program, and some people have expanded the program to include people with thoracic and cervical pain. My only comment would be that any adaptations must always stick to the same message, and it's really important that we don't give mixed messages to patients, but that actually the CB approach is carried through whatever changes that you make. Should only experienced therapists run the group? No. More experienced staff may be more confident to deliver the program, but we haven't found any different in outcomes based on grade of staff. Less experienced staff may need some support, and at some sites they've done a buddy system to support less experienced staff during their first groups. I would say the most important thing is that staff need to be enthusiastic about using a cognitive behavioural approach. During the last 12 months, this has probably been the most frequently asked question. Can we run the groups online? And although we haven't evaluated the BEST program in this format, we know that some sites have successfully been running groups online through programs such as Teams. We have put together a deck of PowerPoint slides, and we're happy to share that with people if they would like to use it to deliver the groups online. Feedback from sites such as Cambridge Community, who I know have run at least 9 groups online, is that they have had to adapt the exercises to make them easier to demonstrate online by using more functional exercises. In the one-to-one sessions, you need to make sure you include information about how to access the online groups, and you need to send out the patient workbook prior to the group. This can be either via email or a printed copy posted. And I know that some sites have then offered telephone calls to people if they've had any access problems getting onto the online groups. So I would just like to close with a quote that we received as feedback from a patient who took part in the implementation study. And it really sums up why it's so important to provide this type of treatment. And I'll just give you a few seconds just to read that. So if anyone would like to get in contact with me, here's my email. Please feel free to contact me. And I would also encourage you to go to the FutureLearn site and to have a look at the training. There is a free version of the training that anyone can access, and I would encourage you to do so. Thank you for listening.
I'm not sure if I've got a bit of a lag.
Feel free to contact me. And I would also encourage you to go to the FutureLearn site and to have a look at the training. There is a free version of the
No, the video is finished. You can introduce the speaker if you like.
Sorry, video's still running for me. I must have some sort of lag. Sorry about that. So that was Esther Williamson. So I'll just give you a bit of background to Esther, and then I'll give you some information about our next speaker. So Dr. Esther Williamson is the Deputy Director of the Centre of Rehabilitation Research based at the Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Science at the University of Oxford. And in September 2020, she also started a part-time position as a Senior Research Fellow at the University of Exeter. And she's been involved in the BEST study, which she presented there. And there were some training resources and implementation studies that she's very kindly told us a little bit more about. So, as I say, apologies, I seem to have a bit of a lag, so sorry there was a bit of a gap there. Our next speaker is Ruth Newsome. So Ruth works as an extended scope physiotherapist in Sheffield. She's also a representative in the National Back Pain Clinical Network for Yorkshire, Humber and East Midlands. And Ruth and I have worked to organise this session today, and so I've really appreciated her assistance over the past few months. Thanks, Ruth. Ruth has got a real passion for providing high quality rehab for her patients, and she's going to outline how she has been developing her CPP programme in Sheffield. Thank you.
This is a journey of developing a CPPP programme with a functional rehabilitation back group. It seems like a successful CPPP delivery is the holy grail, and many of us are still hunting down the ideal way to deliver it before COVID. I was asked to speak having run a comprehensive back rehabilitation programme and developing it to include CPPP components, and I'm still on the journey. I will outline what was happening before COVID when we ran a functional goal-orientated back group, evolving it as evidence suggests with psychological aspects, but recognised we could make a stronger package, adding higher psychological components. We felt confident with back rehabilitation exercise and needed to deliver CPPP in line with the guidelines and evidence. We had certain skills, but we were aware of needing help, such as increased pain clinic input to increase the multidisciplinary contribution. Then I'll speak about what we've done so far since COVID, developing ways and using opportunities to deliver a more comprehensive back rehab programme through virtual means, and how we may develop CPPP in the future. We're not fully where we want to be yet, but feel we have the means to get there. In Sheffield, we're still a work in progress, and looking at our current services overall MSK, both primary and secondary care, and the components for CPPP existing current services. So we're looking at how we can use these to develop a programme. Does the group fulfil the back pain pathway recommendations? Can we use them to create a case for funding for further training? Can we provide the appropriate combined psychological and physical support? Can we identify patients at risk earlier in the pathway with tools like the Start Back? How can we provide a more intensive programme for the highest scoring patients? Remember these days before COVID, this is a secondary care group, and all patients have been referred from secondary care clinics, and also include patients identified by Pain Clinic that may benefit from rehab, which is an example of using services and resources we have already, sharing skills without extra finance. By nature of referral, most of the patients have had copious amounts of unsuccessful physiotherapy in varying degrees. A rebro has been used more recently to help direct the nature of treatment, and programs are tailored to the patient's needs in order to achieve goals. NICE, MBR and CPPP guidelines included unidisciplinary papers demonstrating that a program can be delivered by one profession with appropriate skills. We have a rolling program, so we may have a patient about to be discharged while a new patient joins. The new patient has a review of their goals and expectations along with the bespoke exercise program. Patients can choose location at either the hospital or sports centre. The sports centre helps to demedicalise, and with the attendance of a fitness instructor, bridges the gap for continuing self-management. There is an attendance charge of £2 per session for the venue, and this was brought in to encourage value to rehab and behaviour change to ongoing exercise, as well as towards facilities. Physical measures are based on the Harding scale. This is useful feedback for both the patient and therapist. And patients are given up to 8 sessions with weekly individual review. Some may require fewer and some may require extra, as one size doesn't fit all. Patient involvement has been crucial to shaping the format and delivery of the group throughout. We have a close working relationship with the sports centre, and I've delivered back pain training to the exercise referral specialist fitness instructors to help with the same themes and messages and confidence of the patient. The patient is asked if they're happy to be contacted after a year to see if they've continued activity and managing their back pain, but this is emphasised, it is not a resumption of treatment cycle. Inclusion criteria is in line with the back pain pathway and guidelines referrals. We have referrals from pain management, and we can refer to them using a multidisciplinary approach as recommended by NICE and the back pain pathway as an endorsed resource. And of course, groups aren't necessarily for everyone. Goals are SMART, and we also have a patient feedback book for developing and evolving the service. Does it work? Is it effective? Well, we've done a number of service reviews. This is one where I've underlined the new patient who never made it to a back group session, which were 25. This is important for identifying why. Is this how the back group's been sold to the patient? Are the needs not met? Is it a training need for referring physios? Examples of the qualitative feedback book we use. This gives things such as previous treatment, some mental health benefits and lifestyle, along with, more importantly, a lot of saying they still have back pain, but are coping with it better. One of the quotes here is, "I didn't want to come at first. I felt it was going to be a waste of time." A study was done by one of the spinal rotational physiotherapists on the patient feedback book. We also reviewed the cost effectiveness of the back group at the time. The cost per patient was calculated dividing the total cost of sessions with the staffing and venue over 2 years by the number of patients at that time. We also looked at whether attendance at the group may decrease representation to spinal healthcare services. If opportunities continue with rehabilitation via the activity referral scheme, could this be a factor for having an influence on it? And it may be. As with many services, the back group in its previous form was decimated, so I began the long task of creating a virtual service. There were many hurdles to jump over. I was often hitting brick walls. The trust was totally against using any platform but attend anywhere. I obtained a Zoom risk assessment kindly supplied by the Physiotherapy Pain Association, but it was still a definite no. We ran 3 different pilots with patients past and present. 2 of these were on the Attend Anywhere. The first group we tried was a hybrid with physical attendees in the gym and virtual participants at the same time, but that wasn't working. Then we were told MS Teams could be used. On the 3rd attempt, we booked a room with good equipment, with soundbar and large screen. The Trust now has a MS Teams use pro forma to use for groups, and risk assessments are done for the virtual class. Need a lot of admin support for the booking system with the MS Teams pro forma, and patient information about the group is sent with the link to the back group. All the patients are individually assessed face to face. We haven't yet referred new patients to the group from total virtual and wondered whether this can be done with the same engagement or not. Patients were identified in the same way as the physical group, but needed the ability to use IT for obvious reasons. We finally started a virtual group in February, and patients are given the option of individual consultations if they have issues to address in confidence in the form of a telephone call after the group. We have a patient representative on it and allow an hour and a half currently. Patients have functional-based exercises at different ability levels, and information on different topics or subjects is given afterwards, but this is optional to the patient. Staff are 2 physiotherapists and a pain clinic practitioner. And at present, patients are offered the choice of combining virtual group appointments with some face-to-face. And I've recently obtained funding and had equipment installed. There's lots of possibilities for developing in the future. It's too soon for current data, but patients are opting to be rebooked regularly and said it was better than the pilot. It has given us much more scope to work with other disciplines. We're planning to look at running a second group with more focus on intensity level of psychological input, but also trying to keep the bespoke element. There's possibilities or opportunities to liaise with other physiotherapists in different trusts. And these are examples of trying to evolve our service with the evidence and what resources we have. And I'm happy to share any resources or experiences of any physios hoping to deliver similar things. If anyone is interested in any of the resources or the type of patient information or exercise and movement, MS Teams pro forma I use, please message. Thank you. This is a journey of developing a CPPP program with a functional rehabilitation back group. It seems like
I think, are we doing Dave Rogers next?
We are, yeah. So we dropped Louise again.
She's very kindly sent me his details.
Fine.
So
I'll play Dave Rogers and then we'll get Louise back in.
And I'm quite happy to introduce him. I've got the details in front of me. Dave works as an advanced practice physiotherapist at the Royal Orthopaedic Hospital in Birmingham, and he has experience of working in occupational rehabilitation as well as the NHS. Dave has been ahead of the game with regards to CPPP with a functional restoration program and has been running this for 10 years. He's published the results of his program and he's going to talk about today, and has co-written a book called Back to Life on the subject.
Hi, my name is Dave Rogers, physiotherapist at the Royal Orthopaedic Hospital in Birmingham. I'd just like to thank Louise and Ruth for inviting me to speak to you today about our combined physical and psychological treatment programme. So I'm just going to start by just sharing my screen and popping a few slides up. So I'm an advanced practice physio working in spinal clinics. I work as a first contact practitioner, but part of my clinical role is to run our what we call our Back to Life program. Originally set up in 2012, it's a 12-hour interdisciplinary group-based program, very much underpinned by a biopsychosocial approach and using cognitive behavioural principles. The service was originally set up with one team, which was myself as the physio, an orthopaedic physician, and a pain counsellor. And we had some admin support just to help us to run the logistics of the programme, which are by no means straightforward. Patients come for 2 hours a week for six consecutive weeks, and then we have a follow-up session about a month after the final session. All of the ingredients you would expect to have on a combined physical and psychological programme within the programme. So we spend time explaining pain biology to patients, addressing any maladaptive beliefs they may have about their pain. Quite a lot of focus on activity management, so looking at those people that tend to have an avoidance pattern of activity, but also those that have as much trouble with overdoing it, so pushing themselves too hard. We do a lot of coaching on trying to help people to manage any setbacks in their pain, so having a clear plan for flare-ups, a kind of an emergency setback plan. And then the doctor does get involved in trying to help people to optimise the use of pain medication, and most of the time that involves reducing their reliance on analgesia, which, as we know with back pain, is not really recommended to any degree anymore. From a behavioural perspective, there's a lot of focus on graded exercise, so we use strengthening, stretching, aerobic exercise, a lot of coaching around relaxation and guided imagery, particularly for those people that have a tendency to overdo it and push themselves too hard. Everything's underpinned by goals, so very much a focus on a goal-setting approach, and really trying to equip patients with a toolkit of strategies to help to get back to life, as it says on the tin. So most of our referrals come from within our secondary care service, so advanced practice physios, spinal surgeons and physicians. However, we are now, as probably a lot of you are, moving out into primary care. So first contact practitioners are referring patients in more and more these days. Physios can refer directly, and as can GPs. And most patients that have been through have received core therapies, primary care management, analgesia, and some of them may have had a workup, medical workup through a back pain clinic. And following, so patients then come in and they have an assessment for the programme. So some people we put straight onto the programme. Some people we may feel from a motivational goal setting perspective, we need to do a little bit more work on them. So we may see them from one-to-one sessions. We do use the start back, but not as a decision-making tool, just to help us to make an informed decision as to whether we feel that psychological or social obstacles are getting in the way of this patient recovering. In terms of outcome measures, a few different examples here. So just on the left is just a quote from a patient. Since COVID, we've moved on to an online service. So just some fairly positive feedback from a patient there. We've done a long-term evaluation of pain self-efficacy and Oswestry Disability Index scores. So the blue column is at baseline, the red column is at 4 weeks. We used to do a 4-week program, and the green column is mean of 27-month follow-up. So pain self-efficacy scores, so the improvements in pain self-efficacy are maintained over the long term. There is a little bit of a drop in pain disability scores, but it's still significantly better than it was at baseline. We've also audited our patients' medication use and demonstrated a cost saving per patient from a lot of the input that the doctor provides on the programme. I've also trawled through some of our informatics coding and asked the question, how many patients who've attended a programme go on to have spinal fusion and spinal injections? And I think you can see from the results there that the numbers are very minimal, without any patients which we've explored have gone on to have spinal surgery. Louise and Ruth just asked me to put some information up about our inclusion and exclusion criteria, which hopefully is fairly self-explanatory. So it's persistent back pain. There may be occupational issues involved, or it may be just that the patient is actively seeking to improve their function and quality of life. Key to it is identifying psychosocial factors that we think we can modify. We obviously can't modify all of them, but we're really looking for patients who have got factors that are modifiable. So the pandemic came along 12 months ago and put all our plans into a complete mess. So we quickly fell in love with Zoom. But to set a program up online, we had to get some help from our information governance department, our comms department, IT. We used the skills of our expert patient to help to redesign our program, and we also got some help from our clinical team within Back to Life. So I'm just going to jump out and jump into a different screen now, just to show you a little bit of information on our service itself. But before I do that, I just want to show you a short clip of a patient of ours who recently attended a program, just to give you a bit of a feel for what actually happened. So
I'm far more active than I've been. I can touch the floor with my knuckles. Before I probably wouldn't have touched my knees because I thought I couldn't. Quite happy to exercise when my mind's ready for me to exercise, but that was rare. And the idea of coming to a gym and working out with a group of people was a bit daunting, so I can understand other people feeling a bit, sort of stressed at that. But actually I wanted it. I wanted the benefit far more than anything else. So I think my advice to anyone would be to always have an open mind about it, because, with persistent pain, and I'm the first advocate of this, we quite happily look at the negatives because that's what we're used to dealing with. So I think an open mind is the most important thing, because if you come into it with an open mind, set yourself some realistic goals, you've got the team and the group to encourage you to do it. Talking about
So I'm just on our website now, so roh.nhs.net, and within the website, since we've set up the programme over Zoom online, we've really gone to town with our website. So if any of you want to pinch any of our ideas or any of our work, feel free to do it. I'm not protective about this at all. Within each session that we run online, there are lots and lots of resources that we've put together. So as an example, all of the sessions that we've done are recorded and are available for our patients to have a look at pre and post programme. There's lots of videos on here. We have an audio file of our pain counsellor for relaxation. Lots and lots of patient stories, patient videos. So this is a really useful resource for any of you that might want to find more information about the programme. So just back to me. So just a few reflections. Had to go through quite a lot of cultural change within the hospital, initially with spinal surgeons, but also with some of the physios, because although these types of programs are available and are recommended, they're recommended, they're just not very available nationwide. I was fortunate in being able to have a funded role to be able to run this program, but you do really have to work on the cultural change, communication. There's obviously lots of different departments I've introduced into our service to try and help support us. But I'm fairly convinced that this is a really good treatment option for our patients. I just think we've got to do a lot more work on trying to improve the provision of it nationwide. So honestly, feel free to look at anything on the website. If you want to take any ideas, if you want to speak to me, I'm more than happy to speak to you. david.rogers4@nhs.net. Again, Louise and Ruth, thank you very much for your time. I'm just about to hit 10 minutes, so that's me done. Thanks.
Okay, thank you very much, Dave. I can see a few comments and questions coming in for you later. So our next presentation is a joint presentation with Amy Thomas and Tom Enfield. They are based in Wales and work for Cardiff and Vale University Health Board. Amy's been working in their Back to Action CPPP since 2013, and she became the team lead in 2015. She's currently actually on maternity leave, so I'm really impressed and very happy that she's able to participate in this session this afternoon. Tom Enfield is currently the service lead, and as well as his clinical work, he's working towards an MSc in long-term and chronic conditions. The Back to Action programme that they run in Cardiff has won the Prudently Advancing Practice Award in 2016 and at the Advancing Healthcare Awards. Amy has presented the service both at national and international events. So thank you very much, both of you, for your presentation today.
Hello everyone, and thank you to the organisers for inviting us to present our service to you. My name is Amy Thomas and I have been leading the Back in Action programme since 2015, but I'm currently on maternity leave.
And my name is Tom Enfield and I'm acting team lead of the Back in Action programme, which is based in Cardiff and Vale University Health Board. Back in Action was set up in 2012 and is a CPPP for individuals living with persistent low back pain. Today we hope to provide you with an insight into our programme's content, staffing, processes and outcomes. This is the service pathway that we use in Back in Action. We accept any adult service user with persistent low back pain that is high risk on the Kill Start Back tool, or those with identified psychosocial barriers to recovery. Our inclusion and exclusion criteria are very similar to those that Louise presented at the beginning of the session. Once referred, patients attend a group introductory talk where we introduce basic pain physiology and the cognitive behavioral therapy hot cross bun model that links sensations, thoughts, feelings, and behaviors. They are then given the option to opt in or out of the program. We have found this approach greatly reduces any non-attendance rates and allows us to ensure the service user is ready for behavior change while being fully informed and involved in their treatment choice. Service users that opt in then attend an hour's subjective assessment with 2 members of our multidisciplinary team to discuss their journey and current situation. Each service user is then presented at a weekly multidisciplinary team meeting to ensure the individual's goals and needs will be met by the program, and if not, considering a better team or time to provide treatment. We then feed this back to the service user and collaboratively make a joint decision on their care going forwards. The intensive intervention is 58 hours, delivered in 9 full days over 3 consecutive weeks. It's run in community venues around Cardiff and the Vale to ensure easy access for all and provide a non-medical environment for service users. We deliver the intervention in groups of up to 10, and it consists of a combination of psychoeducation, interactive group sessions, and exercise. To give you an idea of what a day on the program looks like, we start at 9:30 with a discussion based on that day's theme or particular acceptance and commitment therapy topics like experiential avoidance. This is followed by a 45-minute daily circuit that combines a graded exercise program and exposure work. After a break, we facilitate an educational session on topics like pain physiology or pacing. The afternoon starts with a second education session, followed by a further 60-minute exercise session that could be hydrotherapy, the gym, or recreational exercise, which is often activities like bowling or walking netball. The day is finished at 3 p.m. with a session of relaxation or mindfulness. Following completion of the intensive component of the program, patients have 6 months of optional fortnightly follow-up sessions, which we find key in aiding the transition to the individual confidently self-managing ongoing symptoms or setbacks.
So our MDT, it consists of 3 senior physiotherapists, a clinical psychologist, a clinical specialist pain nurse, an OT, and a physiotherapy technical instructor. And we believe that this MDT mix is crucial in providing the knowledge and expertise to address complex biopsychosocial factors and the barriers to recovery. We work closely together to share our knowledge and experience, which ensures the patients receive consistent and clear messages throughout their time in the service. We use acceptance and commitment therapy as our CBT model, as it fits really well with participation and valued living and has an increased evidence base in the management of persistent pain. All our team members have received formal ACT training, which allows us to embed this approach into all aspects of the service. Our team feel that this shared ACT delivery is a key factor in enabling us to challenge unhelpful cognitions and behaviours, reducing psychosocial distress, and providing tools and techniques for long-term management. Importantly, we're able to continually refine and develop our ACT skills through regular mentoring with our clinical psychologist. In order to gain a better insight into each individual service user and monitor how effective the programme is, we routinely collect 9 outcome measures, 6 patient-reported outcome measures, and 3 physical. And you can see these on the slide. We collect these at 4 different points along the pathway, including pre- and post-intervention.
For this evaluation, we sampled data from all service users that completed the intensive component of the programme between January 2015 and January 2020. 317 service users provided us with a complete set of data to allow us to identify any clinically significant changes in outcomes. Overall, we also found that each one of the 9 outcomes demonstrated an average change greater than the clinically significant value, with 99.5% of patients achieving at least 1 significant change. This demonstrates that the Back in Action programme, delivering over 5 years, can reach consistent results, showing effectiveness at reducing pain-related conditions that play such a big role in persistent pain mechanisms, as well as increasing functionality and reducing disability.
So there are key components that, upon reflection with our founding and our current members of the team, were fundamental to developing and establishing our service to become what it is now. We feel the MDT is the most crucial. The MDT works together with a consistent and shared message, but we also draw on each clinician's individual skills. We feel developing the team approach using ACT has enabled the optimal approach to achieve successful behaviour change. The team regularly provide peer-to-peer support, but we also have regular mentoring from our individual specialities. Our first programme in 2012, and up to this day really, there is a little guidance in terms of what CPPs should look like. Although this has its obvious challenges, the upside to this has been we've had the flexibility to continually refine and shape the service using extensive co-production methods to ensure every aspect of what we deliver is relevant and helpful to this patient group. Particularly in the first few years, we were met with significant challenges in terms of commissioning, establishing substantive funding, and also embedding ourselves in the local low back pain pathway. Cost was a big challenge, and CPPPs are often seen as very expensive, but we were able to show significant improvements in people's valued living and participation for similar costs to a nerve root block. Other vital components have been a number of individuals outside the MDT whose support has been hugely influential. And without allies at board level and in other areas such as orthopaedics, academia and psychology, we wouldn't have been able to build our service or to be able to offer the level of care that we can now.
Adaptation to the virtual world has seen only changes in the programme delivery component. It's become 3 days a week for 3 weeks for roughly 3 hours in a morning. We collaborated with previous attendees to the programme to identify the key components that we should deliver during the virtual version. Though it isn't designed to replicate the normal, it is our current best offer. In order to meet the previous version's capabilities, we have considered a face-to-face top-up for those that have completed the virtual sessions when we're able to do so. Our team feel our virtual version has a bias towards delivering content rather than the collaborative effort of the MDT and the group, with reduced peer-to-peer support. The loss of the group component does feel like it could be negative on patient experience and potentially outcomes. To combat this, we are looking to increase the amount of time in breakout rooms and space with and without the clinicians to develop a sense of togetherness whilst on the programme. Early learning points, though, is the ability for those to attend that have reduced levels of physical capability or challenges with travel. We are constantly evaluating our outcomes and getting as much service user feedback that we can so that we can consider whether there is feasibility in offering 2 different versions in the future. We feel our CPPP programme demonstrates the capability to reduce psychological distress and support individuals towards valued living with an ACT format that is replicable for other healthcare providers. Our format of frequency and participants has proven clinical effectiveness and prudency. Please feel free to ask any questions of us later in the session, and we've also included our email address here if you wish for further conversation, as we're always passionate and interested in supporting CPP success. Thanks very much for listening to us.
Thank you.
Thank you again for another excellent presentation. So our final presentation is another joint presentation. So Ronan Walsh and Adam Dobson are both specialist spinal triage physiotherapists who co-lead the South Tees Hospital Foundation Trust CPPP in Middlesbrough. When they're not leading the programme, they also work as specialist back pain within a specialist back pain clinic. Their programme has been running now for over 5 years and has been continually updated over this period. So they've got outcome data for the programme, and that has been published in the Spine Journal, and they're going to share their experiences about the programme today. Thank you.
Hi, my name is Ronan Walsh. I'm the co-lead of the South Tees Hospital's residential combined physical and psychological programme. I'm a specialist physiotherapist working in a back pain triage clinic. A brief overview and history of our programme. Our area was chosen as the pilot site for the North of England Regional Back Pain Pathway. And the first programme, residential CPPP, was ran in early 2016. Our programme is a 100-hour residential programme, which we run in a hotel setting in the Middlesbrough area. So it's a very intensive 3-week programme, and it is based on the exact guidance from the NICE guidelines. At the moment, we have joint programme leads, and both of us are physiotherapists, so we have a real enthusiasm for rehabilitation and helping patients. But we also have a multidisciplinary team which support the programme, and that includes clinical psychologist input, specialist nurse input, pharmacist and dietitian. Other aspects that we also include our Facebook group for patients to be able to support each other following the programme or even during the programme. And we also have a number of exercise taster sessions, and that includes yoga, Pilates, Nordic walking. We try and give patients a good breadth of experience of different management types in terms of exercise. Participant selection. So I work in a back pain triage clinic, as do the rest of our team. And all patients who come onto our residential programme have been through the back pain triage clinic. Currently, our programme is commissioned for 60 patients per year, and this is out of an area which has a total population of approximately 400,000 people. And currently, we see approximately 5,000 patients per year in clinic. So we have 60 patients going through out of 5,000 patients who are seen in clinic. So it's quite a small percentage going on to such an intensive management strategy. The programme is providing service for 4 CCGs in the area. However, the vast majority of patients come from 2 CCGs only. Predominantly, this is due to commissioning difficulties and differences, and which primarily centre around the chronicity or duration of a patient's pain. All patients who are on our programme have been stratified as either a medium or high risk using the Start Back tool. So these are patients with generally high psychological risk of developing chronic pain. And of course, most of our patients do have chronic pain or persistent pain. All our clinical staff who work in the back pain triage clinics are aware of all the requirements and expectations of patients who would be seen and referred to the programme. And all our staff have had experience of being on the programme, so they know exactly what the environment is like and what is entailed. We also have implemented a more recent strategy to reduce patient DNAs, and of course to manage expectations. We have a patient information video and quite a lot of information on our website about the programme, which is called the Back to Health programme. And we give patients this information either via email link, or we can direct them using hard copies as well. And we then review the patients about 2 weeks later. And the reason for this is to ensure that they have had a time to read the information, of course, and of course to deal with any concerns or questions that they might have. Quite often patients will come back for the review appointment and essentially say that the programme really isn't for them, and it is better to manage the patient's expectations as soon as possible in their journey. In terms of outcomes for our programme, the implementation of the regional back pain pathway was evaluated independently by Teesside University, and there's been a number of papers published over the past number of years. Now, this research is available, and the back pain pathway chair, Dermot Ferguson, I'm sure will be happy to share this research with anybody who is interested. So I'm going to pass you over now to my joint lead of the programme, Adam Dobson. He's going to talk about the difficulties and changes we made through lockdown of trying to keep the programme running. So Adam, over to you.
So hello everyone. As Ronan says, I'm the kind of co-lead of the Back to Health programme. I also work in the back pain triage clinic as well. So just a little bit on kind of adjustments that we made kind of coming in and out of lockdown. So kind of coming out of the first lockdown into tier 2, we made some adaptations and hosted what you might call a hybrid program. So it was kind of part face-to-face and part virtual. We used a large room so we could socially distance. And we trialled and included some innovative technologies to host some guest speakers, and actually with a little bit of trial and error it worked really well. As Roland says, the program has to be adapted. It's currently kind of being suspended in its current form. Hopefully as we move into tier 2, we'll be able to kind of adapt things and move it closer to kind of that initial iteration. There's probably quite a lot of things we could say in terms of like passing on workable kind of gems of information. But one thing I would say, if it be virtual or face-to-face or hybrid, is to think about the social aspect of the biopsychosocial. Quite difficult right now in the current climate, but hopefully that will become more accessible in the future. So when I say social, not just group engagement, but considering things like having sessions on social inclusion, sessions on local social enterprises, and thinking about guest speakers that include things like work, which we found that actually really enhanced the kind of the holistic approach to the whole kind of program. As with other regions, we've kind of been looking at virtual kind of back skills programs, and a physiotherapist is working on that right now. If you want us to kind of link you up and ask some kind of more questions. Finally, just where you can find us. So if you want us to kind of contact us by email, if you've got any other questions, any other thoughts, you want to go through any of the kind of logistical aspects of the program, the schedule, kind of integration of the biopsychosocial model, more than happy to do that. So on the website, as Ronan said, we've got fantastic resources on the Back to Health programme, but also lots of resources on things that kind of transcend the kind of triage clinic and kind of patient-facing information as well. So please do check that out. And lastly, we're both on Twitter, more than happy to kind of chat and go through things via there as well. So thank you very much for joining today. Hope you found that useful, and we'll chat again soon.
Okay, well, thanks again to all the speakers, and that's the conclusion to all the presentations. So I can see that we've had different comments and questions coming in. Jim, do you want to start us off with a few questions?
Sure. It's fantastic. We've got about 25 minutes, I think, by my reckoning, for questions, which is just brilliant. So thanks, everybody, for sticking to time. That will really enable a full discussion about the sort of critical elements of these things. Can I start by asking Esther, there were a sort of group of inquiries that came in about surgical patients in your cohort, those with coexisting leg pain, and how on earth do you get people to commission these services? So Esther, if you could answer that, post-surgical patients and leg pain, or tips about commissioning, but then there might be pearls of wisdom from other speakers about commissioning and increasing the breadth. They've made the point that we need this adopted more widely nationally.
Yeah, thank you. Great questions. In terms of selecting patients, whether they've got back pain or whether they've had surgery, we haven't really specified that. the best criteria is very broad. We have looked at some subgroup analysis to try and identify people that have responded better to the program. Actually, we haven't identified them. We haven't looked at it using StartBack, because StartBack didn't exist when we conducted the main trial. So there's no reason why these types of patients couldn't come into the groups, because actually, you know, the groups are very responsive to the people in them and talking about their individual situations. So in regards to whether you should or shouldn't include people that have leg pain or whether they've had surgery, I think they would be fine to include, really, as long as they're presenting with the sort of issues that you would address in that group setting. You know, so having sort of psychological factors such as unhelpful beliefs about returning to activities or being active, then, you know, there's no reason why they wouldn't be addressed in this situation. In terms of convincing commissioners, I think that can be quite difficult. And I know we had some problems with people when they first wanted to actually implement BEST, that they had problems with the funding models because they weren't set up for running groups. So they were actually losing money to their department by running a group intervention, because they were getting funded sort of per physio hour. So obviously it's cheaper to then, you can see more patients in less time if you're running a group. So we have put together some materials that people can use to present to commissioners just around the sort of benefits of things. And I'm happy to send those to people if they want. But I think certainly the BEST program has shown to be cost effective and does cost less to deliver than traditional sort of one-to-one physio.
Thanks ever so much. That's really, really helpful. And thanks for agreeing to share those resources. Just on that note, just remind everybody that later today at 4:20, there's going to be a session on knowledge mobilisation and implementation of the National Back Pain Pathway, particularly the CPPP element. So please feel free to join us there. There might be extra tidbits that people will find helpful. Lou, do you want to?
Yeah, I've got a question that was posed for Ruth. Ruth, where do you see the line between CPPP and current community PMPs, pain management programs?
Can you hear me? Okay.
Yeah.
Hello, can you hear me? Yeah, that's great. Sorry, I was just waiting for the thing. I think it comes with the differentiation that you spoke at the beginning in the introduction, Louise, about the difference of what is a strictly more pain management as opposed to back pain, hence the multi-site areas of pain and established. We tend to use, and thinking like the ODI over 50 and generally sort of a Rebro over 50 scores as ones that might benefit more from the more psychologically informed. Regarding Pain Clinic, with how we work with them, we do have some crossover, but they are identified more as those that have potential for rehab. And I say some of that, I think, does come from your subjective assessment as to what the patient says, but tools-wise, it is things like if they've been identified firstly with high start back, and then say the ODI is over 50 and tends to be a Rebro sort of over 50 for ours. The Pain Clinic tend to do a lot more scales, such as your Tampa kinesiology scale, your depression scores, your GAD, and things like that, which would identify more that they're more suitable for a full-blown pain management program.
Brilliant.
Does that answer? Yeah, okay, thanks.
Thank you. Jim?
Thanks, Rick. There was a question that wasn't to any particular speaker, but is of interest, I think, to lots of the people watching this, which will be surgeons. So maybe if I could direct this to Dave, and then anybody else feel free to chip in. How on earth, without onerous sort of psychometric numerical evaluation, does a surgeon in a surgical clinic, which might be 15 minutes, get a feeling for the patients that are more suitable for these kind of interventions? Quite a fairly provocative question. How are they supposed to do that?
I think just asking them clearly whether they have got lots of goals and things they want to get back to in the future. So if they're making clear noises that they want to recover but are struggling and don't know whether it's safe to start cycling or running, or they're asking you questions, is it safe for me to do this? Is it safe for me to do that? As long as you're happy from a structural perspective that everything's okay, you need to look them in the eye and give them a really clear message that it's safe for them to start moving, it's safe for them to start bending and lifting, and make them aware that fear of pain is often more disabling than the pain itself. So I would encourage you to look at, are they fearful of activity, and reassure them it's safe to get going. Ask them about confidence. How confident are you to return to work or return to activities you're avoiding? And just be really definite with them that it's safe to recover, and kind of give them the green light that it's safe to start recovering. So just looking at what their beliefs are about their pain and reassuring that it's safe to get going would be a good place to start.
Dave, thanks. That's really wonderfully succinct. If anybody's got any other things that they would add to that, this would be a great time just to mention.
If I could just say something, Adam, over here on the left. I think that providing a kind of cooling off period, having some really good kind of thought out resources online for the patient to then reflect on. So if it be from the surgeon or if it be from a physiotherapist, being able to kind of conceptualize what rehab is, because it's a bit of a nebulous idea, I think, isn't it, with that small conversation. Kind of giving the patient time to read that information and then kind of talk again. So rather than making a decision straight away, having a cooling off period, providing more information, and then coming back to that might be a kind of way to get around that, or indeed moving that patient to someone in a kind of parallel clinic who could do that as well. Thank you.
Can I just follow on from that? Adam, within your presentation, you and Ronan mentioned about introducing your programme to some patients and then they decide it's not for them. And I wondered if either of you could just elaborate on what the reasons were that patients felt that the programme wasn't right for them.
Yeah, so it varies. I think time commitments come up quite a lot. The social, or the issue of sitting with other people and the kind of anxiety that might bring about. I think also this idea that they can't really picture what it is. I think that's a really big issue as well. And I think someone mentioned earlier that when they do turn up, they kind of say that a lot of my skepticism has been kind of, I've lost that because I can now see what it is a bit more clearly. So I think that, so kind of trying to abate some of those things at the beginning, but those would be the main things from my mind. What do you think, Ron?
Yeah, I'd have to agree. I think the main concern patients would have would be they're quite daunted sometimes by the group situation, and some of these patients, of course, as we've already highlighted, I think in most talks, will have certain psychological issues. So whether we're talking about anxiety or depression, and entering a group situation when they're quite vulnerable, I think can be quite a difficult situation to put themselves in. So as Adam said, having that cooling off period, giving the information, puts the power in the patient's hands, rather than as clinicians we make decisions for them. We try and empower our patients so that they can make decisions about their management plan and whether the program is for them. And of course then discuss other options, even though we'd probably all want them to go on our programs, but I think we have to give people choice.
Can I add something in on that? I agree with everything that Ronan and Adam have just said, because we do a very similar thing where we have a cooling off period after our initial talk, and we find that it really helps identify patients that are ready to change as well. So those ones that perhaps aren't quite there yet may not engage in the program, and they may not come along to the first assessment, but the ones that are in that situation, that they've that time is right, we tend to get really good engagement with that kind of cooling off period as well. So yeah.
Yeah, and I think if you're a surgeon or you're working in a clinic and you don't know much about these programs, it's important just to think that you're just planting a seed. that actually these programs are recommended now. There's some good data backing them up. So, have a look on the website, have a read of this information, go away and have a think about it. And often patients they'll ask around and they'll have a bit of a read around. So you're preparing them for change, preparing them for a different approach to what they may have perceived was going to make them better. And often if they then attend for an assessment, they're on board and they can get going. But definitely planting the seed in clinic is a good place to start.
Can I just add one other thing? I think as working as physiotherapists, we're sometimes very happy to ask for an opinion, when it's appropriate. And I think the same should be, in the opposite direction. That if you're a surgeon unsure of a program like this, whether it's suitable for patients, just ask for an opinion from us, and we can see the patients in clinic. We've got a lot more time to give them. We can discuss and obviously, judge whether their readiness to change and they want to commit to an intervention like this. So I think that would be my main comment on that.
Can I just make a point here that to follow on from that? There's a session on Friday morning about communication that's deliberately perhaps aimed at the surgeons and how they might conduct those conversations. Matt Lowe and Dermot Ferguson in conversation. So that might be something that interests people if that was the nature of your inquiry. Thanks, everybody. Brilliant so far.
Mm-hmm. So could I ask a question, Amy and Tom? Maybe this is one for you. So we'd had some questions and comments about what type of training that might be required to be able to run these programs, and some suggestions have already been made. But I wondered if you had any thoughts on that. And linked to that, I know that your program is underpinned by the acceptance therapy. So do you want to talk about that and why you feel that that's a good line rather than CBT, for example?
Yeah, lovely. So the first part of the question then being what training we think is suitable. For us, we have training at Cardiff University. There's an ACT course there, which all of our team members will go on, which is a 10-week program, which we kind of do once a week. We do in our own time, and then we use those skills then in our day-to-day practice. And alongside that training, we have regular mentoring with our clinical psychologists. So I think we learn the theory, but a lot of the time the confidence to use it in action, to troubleshoot with it in a particularly challenging assessment takes time, and having that kind of psychologist backup to help us to refine that, it seems to really help in how effective it is and help us kind of use it in a much more helpful way, really. We like ACT because we can use it in the group, we can use it on an individual level, we can use it on a team basis to formulate kind of each patient as we kind of review them. And we did use CBT at the beginning, the classic CBT models, but found that was a little bit too time consuming and a little bit more difficult to use in a group. So that's why we kind of like ACT. And it's a lot about moving forwards, and it's a lot about kind of participating in living and moving forward to valued goals, which kind of we think really fits really nicely with a lot of what our patients come to us telling us they want to be different. If that helps.
I think if you're looking for some good training, Esther's Future Learn program is brilliant. It's backed by a high quality randomised control trial. It's the highest level of evidence we've got for this approach. It's really easily accessible. Zara Hansen has put together a very, very good training program. So I would go there as first choice. If I was starting out now, that's where I would go. It's brilliant. And Esther's not paying me anything to say that.
If I can add as well, in terms of like ACT and the principles of ACT, Whitney Scott this morning in the Research and Clinical Management of Pain did a whole session on ACT and what it looks like and some of the components of it. So that might be worthwhile, a bit of a look back there to get a bit of an understanding of what exactly is ACT itself. and then think about how you apply that into different practices.
Perfect. Can I take the sort of moderator's liberty and ask a question for all the speakers? We've still got 10 minutes to go. So there's quite a lot of variation in the programs that have been described in terms of content, in terms of the philosophical assumptions that underpin that content, and most noticeably in the duration, with sort of community programs, short duration up to 100 hours for programs. More or less, these programs achieve broadly similar outcomes in terms of patient when assessed in the aggregate. So, do people think we should continue with these disparate programs, or should we move to a more standardized, minimalist approach so that we can identify what's absolutely the critical components of that broadly, or should we continue with this disparate thing? And B, do we think within these cohorts do you get a feel for who will be the strong responders when you're delivering these programs? And do you get a feel for the people that are just going to drag your average score down and therefore make your programs look less effective than they can be for some?
Can I just say, I think, like Louise and I was saying, it was an exploration of all the different programs, see what works. And as we've always said with the pathway, it's using the principles and what your service could work best with. And it seems great to have, think this is a CPPP program, but then I think that's been part of why it's been so difficult to implement. Because like I said before, it's almost like been this holy grail. What does it mean? What is it? And I think the identification, the different things like Dave's outlined really well as well. Well, everyone has on the outcome measures that you can use. The screening tools are partly there. I do think a lot of it is the feel in the assessment. Like, can they see a goal for themselves? Can they ever see themselves out of it as to what's appropriate for CPPP? And it's a great idea to think this is CPPP and that's what the patient will get. And I think as long as the patient gets the components needed with the proper rehab, the individualised things, the challenges, the ACT type therapy, does it matter in terms of what it's called as a group? But it's in the end, it'll come down to cost with commissioning. So obviously we need to think about what levels of staff, how many and what type of staff do it, I think.
Thanks, Ruth. Anybody else have any strong thoughts on how specifically we to deal with content?
I think in terms of your second point about who does well, who doesn't do well, I think we know pain is complex and it's often difficult, but you often find in a group that there will be, and this is the skill of running a group, which is important to get across if you've not worked groups, but there'll often be one or two people who get off to a flying start, and you can use them as a resource because they get it early on, and their beliefs are addressed successfully early on, and they can be a really good resource. So I think if you're delivering a program, it's making use of the resources of the people within the program to then hopefully pull those that are a little bit slower at understanding it. And it's also important as well when you do a program is to provide the same message but in different formats. So a stand-up talk with a whiteboard, a video, an exercise, a game. People learn in different ways. I think as physios and as clinicians that work on CPPP, we're not trained to be teachers, but we often end up becoming teachers. So certainly having a variety of different ways of getting the same message across is definitely helpful.
Yeah, I'd agree. And I'd also kind of add to what we've seen over the years with identifying suitable patients is we still are surprised every program we do. We may think that someone is going to respond really well and somebody may not have as much potential, and we could be completely wrong about that. You know, we could have somebody make massive gains and improvements and others won't show anything on their outcome measures, and we kind of would have sworn blind on assessment and team meeting that wouldn't be the case. So I'd say that just having a really open mind about when patients come on, as long as they've got identified goals and they want to do it, and there's no reason why they can't do it, we'll accept them and we'll give them that shot. And like you said, often quite surprised. So at the moment, I don't think we have a great way of predicting who's going to do really well and who's not going to do really well, apart from the normal inclusion exclusion criteria that we've got at the moment. And also, some people may not change too much on their patient reported outcome measures, but they could turn around and say that their life is completely different and that they are back to doing all the things that are meaningful for them, but that might not reflect in our numbers. So yeah, we kind of have a lot of caution in terms of evaluating success based on those outcome measures as well.
And just one other point in terms of core components, I've been amazed at how much improvement patients make in terms of their function, their quality of life, their sleep, from reducing medication. I think what we found is the prescriber, whether it's a doctor or not a doctor, whoever the prescriber is on the program, if you've got that type of program, helping people to reduce medication and replacing the medication with other tools can make a massive, massive difference. So I know we've presented lots of different programs, but I think the medication reduction improvement in health has been a huge surprise for me, and I think it probably should be a core component of any program.
Thanks for that. So thanks for all these really interesting questions. It's been really fantastic, some great speakers and some really helpful comments. And I've been reminded that there's the chat room that perhaps we can continue this conversation. Oh, I think I'm not sure if you can still hear me. So thanks to all our speakers really today for sharing their experiences and expertise in this area, and also especially to Ruth, who's helped to organise this as well as presenting today. So today it was never really going to be about finding all the solutions, but really more the beginning for further exploration and discussion. And so what we would like to do is to develop some sort of library of support resources and also a network so that we can carry this on and better understand what the situation is with provision of these type of programmes within the UK. We've got an interest in undertaking a national survey as a starting point to give us a better idea of what is current practice. And if you've got any further questions, comments, etc., then please do contact us. Our emails or through the UK SSB or through the clinical network or on Twitter. Jim, I think you also wanted to make a few comments about tomorrow's session.
I think I've kind of made them earlier, but I would like to finish by thanking all of our speakers. That was an inspirational session with diversity and compassion and clinical acumen, and that just demonstrates the value that we as a profession can add to patient care. That's absolutely phenomenal. So well done. You should all be applauded, and I hope that we can continue a groundswell movement to more broadly adopt these kind of programs for the betterment of patient health. So thanks for all your expertise.